we've got some guests as well, I think, have been joining us, but there's so many people on the screen, it's difficult to keep tabs. So I'll hand over to Rob, and let's get on with it.
Thank you, Chair. James Womersley, our Head of Patient Flow and Care Navigation, has joined us for this agenda item, and the next agenda item will be Kate Pike and Florence O'Reilly. So thank you, Chair. So the Worcestershire System Update, Sturgis Action Plan. I'll assume that the paper is read and that this paper and discussion went through F&P committee on the 6th of July. So many colleagues around the table currently will be cited on the content and the discussions within this paper. At a very high level, I think a couple of the salient points to try and draw out for you. I think everybody is aware of the national and local Worcestershire challenges in relation to the urgent and emergency care landscape, which often illustrates itself with ambulances being delayed outside of the front door of A&E, and then the A&E access targets, specifically in Worcestershire. We as a system and as an organisation, and the provision that we provide, have been subject to reviews over the course of the last 6 months or so. One is the Lisa Levy review. Just some context or background: Lisa was a previous director of nursing, chief nursing officer within the ICB, or at that time actually it was the CCG. And we've also had a review from Dr. Ian Sturgis, who is nationally recognised. He's a geriatrician by background, works for ESIST at national level, etc. And I think if we took the two reviews, Lisa's review was very much operational, particularly looking at our onward care team and some of the operational processes and learning opportunities related to OCT. Ian's has been more so tactical, more so across the system, looking at health, the acute, the health and care trust, and social care. And both of those reviews have informed strategic and system development opportunities that are monitored through Home First Committee, which is the system integrated partnership approach to improving our urgent and intermediate care agenda. Within the paper, I think there are 7 areas that are priorities for us, and we're making good progress in relation to those areas. So, development of Care Navigation Hub. James has really taken the lead on that, and James may provide more detail if required. But the key point around that is we're looking at going live with our Care Navigation Hub from the 1st of October this year, and that's to bring together to align a team of teams, including our capacity management team, our onward care team, potentially with mental health involvement, Pathway 1 reablement, etc., etc. There's the ongoing development of our OCT offer, our onward care offer. That's very much the interface with acute services to support acute colleagues and patients out of the acute back door, either back home or into our community hospitals. And that's particularly in the context of developing processes to support 7-day working. There's a piece around the improvement of equipment provision. Often we see, and particularly Dr. Sturgis and Lisa have identified challenges with discharge from acute hospitals, often related to the challenges around clunky processes in relation to securing equipment provision to enable people to return home. There are 2 recommendations or actions that are very closely aligned. So within our community hospitals, how we enhance our grip and our processes around board rounds and ward level actions in relation to ensuring that the patients that are in our hospital still need to be in hospital, and if they don't, that we're taking actions to get them home or to their next destination as quickly as possible. But linked to that is the rollout of our digital bed management software system. That's something called the Maya system. We've gone live with the project implementation 4 weeks ago now, and we've set an ambitious target for that system to be in place by the 1st of October. The final two recommendations, one relates to the rebalancing of capacity for what we call Pathway 2. So this relates to the flow out of acute hospitals. Pathway 0, simple discharges. Pathway 1 is home with support. Pathway 2 is into a community hospital bed. I'm very much simplifying that, but we need to change the profiles really and concentrate more on getting people home, either through Pathway 0 or Pathway 1, and reduce our reliance on bedded capacity in our community hospitals. And then the final recommendation and action for us, which is an ongoing process, is around integrating our IPC processes. Mindful that when Ian and Lisa did their reviews, it was in the depths of winter where we were experiencing particular challenges around COVID. Lots of good action across the system around aligning our IPC expertise and discussions to get a shared approach to managing IPC challenges, particularly around COVID in inpatient areas. I'll take a breather there, apart from just to say that the governance, we have fortnightly operational reviews of this plan. That's delivered through my senior management team, James, and the SDU associate directors. Externally, we report through the weekly COOs and also through the monthly Home First Committee. And then we will report our progress against these actions also internally through F&P Committee. So I'll take a breather there.
Thanks, Rob. We clearly have a plan in place, and this is our plan is part of the bigger plan, and this is a in the top priority list. And there aren't too many in the ICB, but getting this plan to get some traction and improve the urgent emergency care pathways is an ICB top priority, and this is how we're playing our part. So, Janet.
Yes, thank you, Rob, for that. I'm not on F&P, so apologies if this has already been discussed. But I can see the actions and the progress, but what I can't see in the paper, and what I don't think you mentioned, is the overall timeline on this. So when will we know we've completed the actions? And then the thing which I think is really important is, how are we measuring that actually our actions have had an impact and have made a difference to the overall, in the overall system, and how are we going to evaluate that and report on it and maybe make changes if we need to as we go along?
Rob, I think you can pick that one before I move to Sue.
Yeah. Thank you, Janet. So I think at a high level, the actions are summarised in table 3 on page 97 of diligence. So the Care Navigation Hub, first phase in by October, and that set out the time frame for completion. The last of those actions being June next year, June 24. With regards to some of the metrics or the measures, what we're aiming ultimately to achieve on behalf of the system is supporting the system this year with the 76% access target for A&E, moving from around about 65% currently, and also supporting the CAT2 ambulance response times to a mean response time of 29 minutes, I think it is, for this year. So those are the two high-level measures as a system. Internally, the areas that we're looking at trying to improve are particularly around our length of stay in community hospitals. We're currently measuring, I'm averaging at around 25 days. We're setting an ambitious target of getting our length of stay down to 20 days.
Thanks, Rob. Sue.
So this might be related to that, reducing the length of stay in community hospitals, but also it does talk about acute hospitals. So I wasn't sure which pathway would you be referring to if we're talking about people who've been in nursing homes, have an incident which means they require hospitalisation and then need to go back to the nursing home, because there are huge delays there as well. And I couldn't see which pathway that would fit into.
So Sue, typically, and James, please add to this if you've got more detail. Typically that would be pathway 3, Sue. So for patients that come out of the acute that haven't been through that route, it is likely that they will come through pathway 2, but then be identified into pathway 3, i.e. into a care home, residential or nursing home. But those patients that would go into the acute via a care home, they would be a pathway 3 discharge, ideally directly back to the care home that they've come from, or an alternative care home. Additionally, I think it's important to highlight that within this plan we talk typically around bedded provision, but key to this also is prevention, and that's very much where our neighbourhood teams, UCR and virtual wards come in. So if there are potential referrals from care homes, there is something about putting the checks and balances in place and looking where our neighbourhood teams, UCR and virtual wards can support care homes in avoiding an unnecessary acute admission.
Thank you, Rob. Martin, I'll be surprised if he doesn't mention prevention, but Martin.
You took the words right out of my mouth, and Rob, you were going there, but this is a very acute focus plan that focus on discharge rather than prevention of them going in there. Is the equivalent, or in better systems, more resource going into avoidance of admission in the first place than actually getting the flow in acute hospitals better? Because actually we all know flow hospitals are acute are a bit of a mess, but if you stop people going in the first place, it's much better care, much better outcomes, and actually should be playing to our strength and the fact that we have the best financed primary care system in the country. Why are we where are we really playing our focus for that?
Really good point, Martin. If I could, I've got a terrible echo there. That's better. Sorry. Really good point. Wherever possible, we would focus on prevention. Some of our discussions in the next agenda item around virtual wards may answer some of that question further. I think, over the last 2 years, we have had investment into our community services, into the UCR model. That's proving very successful, and it's being reflected across the UEC agenda. Our contribution to the prevention agenda, reducing conveyances into the acute, etc., that's moving well. You're right, this plan does focus on acute and the flow out of acute. And I think it's fair to say with Dr. Sturgis's report, he has reflected that 70 to 80% of the challenges around the UEC agenda and his recommendations do sit with our acute colleagues. It's not saying that there aren't things that we have to address, which we are addressing, and it will support overall system flow. But the bulk of this plan, I think it is fair to say the recommendations do sit with our acute colleagues.
I guess if I can come back, are we collecting the evidence, and there's plenty available internationally, about the relative impact of dealing with the prevention agenda than dealing with the after effect of failing to prevent, because the numbers are quite stark in how you can drive better healthcare by focusing on the front end rather than the back end. And I know something that Russell absolutely gets at the Acute Trust.
I think that is something that we do need to develop. We do need to mature our description of the benefits of the prevention agenda. I think that links in also to some of the frailty strategy work that's being developed across the ICB, etc. They're very sound points, and that we mustn't lose sight of those. Absolutely.
You're on mute, Mark.
Yeah, I got that. Sarah, to round up and probably mention sort of system, Sarah.
Yeah, I was just going to remind us of the context of this report, which Rob's partly done now. But Ian Sturgis looked at all of the evidence for the whole part of the pathway, and his conclusion was some of the prevention work, the primary care work, the pre-hospital work was working really effectively. So this report is directly responding to the areas he felt we had scope to improve significantly. So it's important that's the context. So it's not meant to be a complete urgent care transformation end to end. It's really focused on the areas where he has demonstrated we can make a significant impact, and obviously a real focus on making a significant impact before the new emergency department opens and before winter. So that's the context, which is probably quite important, but totally agree with your points, Martin. I chair the pre-hospital group, which is a subgroup of Home First, and that is all of our focus. Certainly Rob's very active in that space, Rob Cunningham, and Joe James, in terms of constantly looking at what else we can do from a prevention point of view to prevent admissions to hospital where it's not appropriate.
Thank you, Sarah. Can I make the assumption that the oversight of this plan will be going to F&P? Yeah, so F&P receive regular updates on the implementation list. Can I ask that it's not just our bit? Yes, we'll focus on our bit because that's within our gift, but can I ask, especially on those outcome measures, I think somebody rightly asked, so if the ambulances aren't waiting, if the patients are getting seen quicker and the discharges are better, that is some of the outcomes. So can I ask that F&P received a sort of a, not just our picture, but the fuller picture with obviously a focus on our bit, if that's okay, Rob?
Yeah, if I can just respond to that, Mark. So I think, yeah, absolutely, we will do that. I do need to reference the great work James is doing. He's really stepped into the space and supported us with developing these plans. We'll make sure that's reflected in our reporting and updates to F&P. And of course, Mark, you'll be mindful of the urgent and intermediate care dashboard that we've talked about literally over a course of a couple of months now, probably a little bit longer. We've got that operationally launched, and at the end of this month, we are anticipating we'll see the output dashboard from that, and that would be really useful, I think, to compile that within the F&P updates.
I was going to say, can you have a conversation with Rob Mackey about how we incorporate that into our performance reports? Because I think that area of performance, albeit much of it is outside of our gift, I think it's important for us to have a view of the performance across the pathway. And so if you could have behind the scenes conversations about how board via F&P could be kept informed of the performance across those pathways, please, that would be particularly useful. Thank you, Rob. Can we note that update, please, board? And then move on to a subject matter which is raising up the agenda, and we started piloting, I think, virtual wards. I can't remember when it was now, but a quick update from Rob, and I believe we've got, I think Kate's with us now. Okay, over to you again, Rob.
Thank you, Mark, and I am going to hand over to Kate. I think Florence joining us, Kate? Florence is our lead ACP.
So unfortunately, I've just put in the chat, huge apologies from Florence, but she's probably not going to, be able to make it. She's delivering an ACP away day down in Evesham. And I think because of the timings, she's not going to make it. So it's just me.
Okay, so thank you, Kate. If I just give a very, very quick introduction. Kate and Florence, who's not with us now, have done a huge amount of work in developing our virtual ward model. Very high profile, both locally, regionally and nationally. I was recently at a number of KPMG workshops in Birmingham looking at the UEC position, particularly for the year ahead and planning for the winter, and virtual wards came up probably in every workshop and every session. There is huge scrutiny and focus on virtual wards. I don't want to steal Kate's thunder because she has brought together a comprehensive presentation to give the background and an update of where we're up to. But just before Kate starts, I'd just like to reinforce and emphasise this fantastic neighbourhood team model that we have in Worcestershire. The neighbourhood teams delivering local services within local PCN footprints alongside primary care and adult social care. When we've seen service developments, whether it's virtual wards, whether it's UCR and other things that I'm sure will come over the horizon, we have a fantastic foundation to deliver that through our integrated neighbourhood teams. So I just wanted to say that as way of introduction. And Kate, I'll hand over to you.
Thanks, Rob. And yeah, good morning, everyone. I'm Kate Pike, Associate Director for Integrated Community Services. Yeah, it's a real shame Florence can't make it. So she's obviously a bit closer to some of the detail than me. So apologies if I won't be able to answer any detailed kind of clinical questions. So I'll share my screen. Okay, can everybody see that okay?
Yes, we can see that, Kate. Thank you.
Thank you. Sorry, just go back to the beginning. So I suppose just to clarify that we are talking here about frailty virtual wards. So there are some virtual wards that are being led by the Acute Trust as well, the heart failure and COPD virtual ward. So I thought to start with, I'd dive into the national definition. So virtual wards are a safe and efficient alternative to NHS bedded care. So they support patients who otherwise would be in hospital to receive acute care. And we're very much looking here at admission prevention as well as supporting earlier discharge. So we're talking about a much higher level of acuity of patient that we would normally support within the community, where we can deliver hospital level diagnostics, provide hospital level interventions with daily input from an MDT, with that 24-hour cover to support this patient group. Another key part is around having the consultant-led element to the service, and I'll talk about that further on. And the length of stay typically is between 1 and 14 days. So the strategic fit, I think you've probably covered a lot of this already, but obviously in line with the long-term plan and growing out of hospital services, and often referred to as the left shift at the moment, very much focusing on home first and getting it right first time. Knowing that we've obviously got huge challenges in terms of over 85 set to double within the next 25 years, etc. And from a patient point of view, we know that there is a lot of harm that can be caused for this patient for patients living with frailty, who, you know, having to wait for an ambulance, travel, queuing, going through the emergency department, and then admissions with prolonged bed rest, obviously cause hospital-acquired functional decline, the risk of infections, etc. So lots and lots of reasons, which I think you've already been talking about in the previous session, to try and keep people and treat them at home. As part of the strategy, I think there's a huge piece to do around culture. So not just around our community services shifting to be able to deliver acute care within the community, but also our acute colleagues sort of recognising actually that things have moved on quite a bit within the community, and you know we can do a lot more with the right resources. So as Rob said, we were successful in a bid to NHSE last year. Our learning phase went live in our Glades neighbourhood team in Wyre Forest in March this year. And as Rob said, it's really important to stress that the virtual ward model is very, very integrated within the neighbourhood team. So with the additional funding, we recruited a frailty GP from our community hospital medic service, a pharmacist, and 4 advanced clinical practitioners. But in addition to this, you've got the whole neighbourhood team resource that's also wrapped around and key to implementation of delivering virtual wards. So just to give you an idea of how it actually works on the ground. So obviously the referral can come in through the usual neighbourhood team route. So we haven't, developed any additional access routes, or alternatively through our urgent community response single point of access. So maybe a patient who is at risk of hospital admission, or it may be somebody in the acute trust where there's an opportunity for an earlier discharge. So far, we've focused more on hospital admission prevention, and we've got quite a bit more work to do with the step down element. So the advanced clinical practitioners very much go out and visit patients within their home and complete comprehensive geriatric assessment. They then, where appropriate, admit to the virtual ward for care, treatment, interventions, and then the patient is reviewed through daily board rounds with the frailty GP and weekly MDT meetings, and obviously follow-up visits as required. And then the patient is either discharged, which may be with no ongoing services, or it may be with back to planned care and existing care services. Obviously, you know, there may be some deaths, there may be some acute admissions where, you know, we feel that we do need to send somebody in. So the learning so far is, I think to start with, we probably, although we were using the whole neighbourhood team, we were obviously looking at the virtual ward as slightly separate, but I think the learning is actually in terms of the whole admission intermediate care caseload that was obviously already there within the neighbourhood team. Actually, there's patients on there who, may have come out of hospital. We may have been supporting them following a chest infection, fall, etc. People may be nearly, well enough to be discharged, but actually, if they fall or develop a chest infection, it means we can quickly step them up to that virtual ward level of support with our ACPs. So the neighbourhood teams have really reaped the benefits of having an ACP integrated within the team, and what that's enabled is for the ACP to focus on the complex patients who are with a higher acuity, and perhaps then frees up, for example, the therapist to focus on reablement and with the more medically stable patients. So far for the pilot, there's 191 patients that have been supported through the Wyre Forest pilot. We found that the new clinical pathways, particularly around the access to urgent bloods, has been working really well. We've also been working closely with our IV team to streamline that pathway. And we are hoping to implement point of care testing, where we can use finger prick technology to get a range of bloods sort of at the patient's bedside within the home. And we're hoping that's going to go live in August. We're just working through the governance of it. And we've started to trial some technology, which is another key aspect I didn't pick up on in the beginning, through there's Docabo, but there's another platform that we're also going to pilot, so we can get a range of clinical observations remotely, such as blood pressures, temperature, etc. And Florence is still working on the X-ray pathway, so that we've got a way into the acute. In terms of interface with the acute, I'll pick that up a bit further on. Just a few statistics which Florence has pulled together. So you've got the top 10 conditions there of people that have been treated on our virtual ward. So ranging from acute, I won't read through all of them, but acute confusion, falls, gastrointestinal problems, heart failure, infections, etc. And quite interesting to look at the Worcester Royal top 6 conditions for attendance in ED for the over 65s. You've got that comparison there. So, and I think actually one of the ACPs that used to work in the acute, feels that some of the patients we're treating at home, are more complex than patients she would have seen while she was working for the acute trust. That's really interesting, and reinforces the direction of travel. That's the breakdown of referral sources. So you can see that actually at the moment, the biggest referral source has actually been from our neighbourhood teams who are obviously dealing with a huge volume of patients on the planned caseload. So that's the beauty of the integrated model, is that we may have known somebody for quite a while because we've been delivering insulin injections, wound care, etc. And actually, if they deteriorate, we can quickly bring them onto the virtual ward. We set out to look at a frailty Rockwood score of 5 and above. So mainly the majority of people have been within that category, but some with lower scores. And you can see the gender split there as being pretty much 50-50. I think one thing virtual wards has really, it's really enabling us to build on collaborative working with our system partners. So we're hoping to do some work with the local authorities wraparound service, which delivers on discharge support for up to 72 hours, and also our reablement service, who deliver mainly pathway 1 but also take community referrals from the social work teams. It's also enhanced our relations with primary care, and we continue to sort of build on that communication to make sure for those very complex patients that, from a continuity perspective, that we've got really robust communication, and obviously that they have been joining our weekly MDTs as well. With the acute trust, obviously the same day emergency care where we can access diagnostics at the Worcester Royal site is something we're really trying to build up. So the plan, if we do need diagnostics that we can't deliver at home, we can send somebody there, but then they still return home and they're not admitted. The geriatric emergency medicine service obviously works closely with ESTEC. And Florence more recently has been having some conversations with the heart failure and COPD specialists around whether we could do further integrated working where people are discharged home sooner, but actually they're still under that care of those specialist consultants. So that's really exciting as well. And obviously our West Midlands ambulance service, we've, as Sarah and Rob have talked about, we've got really good relationships through the work that Joe James has done through the UCR hub. So actually, they can continue to refer through the UCR hub, but it may be that we feel that person needs to be admitted to the virtual ward. So again, all within building on existing pathways. So in terms of the next steps, we are still very much learning in Wyre Forest. There's still regular PDSA, Plan Do Study Act meetings that are going on. And yeah, there's still a lot to do in terms of really embedding the technology and testing out the point of care testing, working on the step down pathway, not just from within Worcestershire, but obviously also, for example, Russell Hall Hospital. And the evaluation, Florence is working on this, and we're really, want to look at the cost benefit analysis in terms of the costs of the additional staff within virtual wards versus the costs of ambulance conveyances and acute bed days saved, etc. And we're continuing to work with primary care colleagues and the ICB around refining the medical model. So for the purpose of the pilot, the House and Care Trust agreed to lead on that. And as I've described, we've had our community hospital frailty GP. Primary care are quite interested in providing some of that cover, but we also know we need that acute special expertise as well. So that's very much work that we're working through at the moment. And then things often boil down to money, don't they? So in terms of the funding, obviously we had funding for the initial pilot. We're waiting on a decision for further funding in order to then roll out to the next area within South Worcestershire, who are sort of ready to go. But we obviously need the funding before we can start recruiting. And very briefly, just to mention, I obviously shared the national definition. There has been talk of that definition changing, but as it stands, that's what we're having to work to. but potentially, if it was altered, there's quite a lot more that we can include within virtual wards in terms of our intermediate care work that we do. So I'll stop sharing to answer any questions. Thank you.
Thank you very much, Kate. That's a great explanation of what we're doing. A number of questions, so kick off with Sue. Sue.
Yes, thank you. I was really interested in that paper and again in your presentation. So, very all power to you. So I've got 3 questions. The first is, to what extent is wire forest typical of other areas that we might be worrying about? And so that we know that what's happening there might be scaled up into other areas. The second is, to what extent does this rely on the fact that the person being cared for has got a carer for the rest of their time? So thinking about, their food and other needs, and therefore, given changes into retirement age, might be jeopardised in the future, because, I'm imagining at the moment, people who are 85 plus might have a child who's in their 60s who could do this, but with retirement ages changing, they might not have that. And the third question is, to what extent would you consider doing virtual wards in care homes? Because obviously many people are in a residential setting, and then when things get more serious, they maybe need to go into a nursing home, for which obviously the NHS might be liable for FNC. So it could be a way of stopping that pathway for some elderly people.
Hey, thanks, Sue. So for why the first question around wire forest, the reason we piloted with wire forest, I must admit, was due to the engagement from our primary care colleagues within wire forest, who were keen to go first. And actually, we felt operationally that the Glades neighbourhood team, in terms of where they were at with their staffing resources at the time, etc., was a good place to roll this out. And I have to say, it has been a really complex journey, and I'm really glad we started off small. In terms of scale up for the other areas, I think because of the virtual ward model, because of the neighbourhood team model being equitable across the county, it's something that we can roll out quite easily in all the other areas as well. I think the bit that we're working through is around what that the medical element looks like, and it may be that does look slightly different in other areas compared to wire forest, but we're just working that through at the moment. The other question around carers. So again, the beauty of the integrated model is that, we do have healthcare assistants within the neighbourhood team who, as part of intermediate care, can support patients up to 4 times a day, 7 days a week, and that obviously is supporting not just with the healthcare elements, but it is supporting them, with personal care and domestic activities. So we would be going in the morning to support with them with getting washed and dressed, and having breakfast, medication, etc., and again with lunch and tea, and supporting with them to go to bed. So initially, actually, we had started. We thought for the model we were going to put in some 24-hour healthcare assistance, but quickly it became apparent that it wouldn't be cost effective and that we didn't need that. And a lot of the virtual ward bit is around that complex the ACP and pharmacist input. I don't know if that answers your question. And then thirdly, just around care homes. So we do obviously have our enhanced health and care home teams that are delivered by PCNs. We do have some ACPs employed by our trust who are working in those teams. So there is, I think, there is potential, absolutely, and I think it is within the national scope for virtual wards that we can support within residential and potentially nursing homes. But at the moment, we're not.
Janet.
Yeah, thank you. Yeah, thank you for that presentation. And can you feed back to Florence? I thought it was a really good presentation. Covered all the areas and very logical. I wanted to reflect back on the discussion we were having much earlier in the meeting about the workforce plan, because it seems to me as though the work that's happening here is actually starting to embody a lot of the themes from that plan, so that we've got people undertaking new roles, the team are working differently, people are getting new competencies that they haven't had before. And so I think there'll be lots and lots of learning coming out of this around the roles and the competencies. So I suppose I wanted to highlight that and just ask, as part of evaluating it, presumably you're looking at the impact on recruitment and retention into the teams, and also the staff and team satisfaction and feedback, and what training they need and what further training they need. I mean, it's endless, isn't it? But I think this is a huge opportunity and one that we should definitely capitalise on. So thank you for that.
Janet, can I just to give Kate a bit of a breather? So just to respond to that, I think you're absolutely right. This absolutely aligns to that people plan and that workforce strategy, etc. This is a great opportunity to develop our workforce. We know we've got limited workforce over recent years. When we've gone to recruit to new roles, etc., we're often taking from another area and leaving someone else short, etc. There's a great opportunity to develop our workforce, things like succession planning, career aspirations within community services, that you can come in as a healthcare support worker and in a period of time be trained up, developed, and be working at an ACP level. And that's a really exciting career pathway and an ambition we can offer to new recruits.
Thank you, Rob. Jamie, and then it'll be Martin.
Yes, thanks very much, Kate. It was fascinating. Really, really positive feedback on this initiative. Sounds terrific. A couple of quick questions. As I understand it, this is a national initiative. I'm not entirely sure how far what we do is prescribed nationally as part of a particular template or model, or what discretion we have. You mentioned about how we'd recruited certain people into the team, so it sounds like we've got some flexibility there. I'd just like to hear a bit more about that. Secondly, I know the evaluation is a job to be done, but presumably the impact that this has on the acute sector is precisely measurable. We will be able to determine from the patients we've dealt with how much capacity that's freed up in the acute sector in a measurable way. So if you could confirm that. And then going on from that, in terms of the rollouts, insofar as this is freeing up capacity within the acute sector, would I be right in thinking that the rollout will be funded by the acute?
I can see Rob's dying to come in to answer probably the first bit. Rob, do you want to?
Yeah, let me pick up on a few bits, and then Kate, please feed in. So, Jamie, with regards to the kind of national picture, etc., there is a clear definition, and that's quite key, and it's something that Kate referenced in her presentation, that the national definition does describe certain criteria and senior medical oversight and the digital enabled support, etc., etc. During the course of the winter and discussions with region recently, we are being asked at regional level to enhance our capacity include existing capacity to enhance our activity and our numbers and our reporting. There's challenge around that, and there is some anxiety around that, because if we do that, we have to be very careful that we're not diluting the model that we're providing. And when we look at the bottom right-hand corner of admissions saved and then potential cost and impact on the system flow, etc., that we're not diluting that. So that is a challenge. We have met with the national team around the national directive, the national terminology and definition. We are being advised regionally that we do have flexibility, and regionally they like our neighbourhood team model and how we're able to flex across UCR, intensive or intermediate care, as Kate's referenced, enhanced health in care homes and virtual wards. So we have got that local flexibility, but we're not fully there. There's more mileage to travel with that. And then with regards to your other questions, I'm sorry, I've forgotten them. Kate, did you want to pick up on any of those?
Yeah, so just around the evaluation, yeah, we have a massive spreadsheet, and we are collecting loads of data, and really working up that evaluation. And there's a registrar who's working with one of the consultant geriatricians at the acute who's involved in that piece of work, and also Worcester University are doing a piece around virtual wards as well. So yeah, hopefully, yeah, I can bring the evaluation back to this meeting one day.
And the question of resourcing from the acute, given that this is freeing up capacity in the acute sector.
So at the moment, the funding is coming from the ICB. Initially, the funding was ring fenced. It's no longer ring fenced for virtual wards. So yeah, that's with the ICB's hand. But I guess longer term, then in line with sort of that left shift, that's where we would want, wouldn't it, to grow the services in the community, and resources to follow sort of out of the acute.
Okay, and then quickly wrap up, because timings are somewhat difficult at the moment. Martin, then Veena, Biraj.
Yeah, can I just pick up on where, Sue, I'm a huge fan of virtual wards. I wish they weren't called wards, but that's another point. Can you just, some of the issues with virtual wards has been about that this is a perpetuation of middle-class medicine, middle-class access enhancement, etc. Are we actually making sure that we evaluate that this is addressing inequalities in a positive way and providing access for those who don't get access at the moment, rather than perpetuating access for those who already got good access?
Yeah, when we started the pilot, we obviously did an equality impact assessment and took that to the equality advisory group. Florence presented it actually, so it's a shame she's not here to sort of talk more through the detail of that. But yeah, absolutely.
Martin, are you?
Sorry, yeah, I'm happy as long as that's.
Sorry, it's a very brief answer.
Yeah,
you look pensive. Veena.
I was just going to make exactly the same point, Martin, and the fact that I think it's really important to tie this in with the PCREF piece in order to ensure that everybody across the board has knowledge of how to access this amazing service. So yeah, I think that's a really important point. And also just touching on a point that Janet raised earlier with the workforce question. We know that levels of staffing is a huge issue across the trust, and actually nationally. And I just wondered how our staffing levels in the virtual ward programme compares to staffing levels in other areas of the trust. Is this an area where it's easier to staff? And what about absence levels? Are they higher or lower? I mean, essentially, I'm just interested in understanding whether it's easier to staff this sort of service, whether we can provide a more efficient service like this, given those staffing challenges.
I think for ACPs, I mean, I think it's a really exciting place to work, isn't it? The ACPs that we've got, I think one is a paramedic by background, and like I said, one has come from the acute trust and one has come from primary care. So actually, that's really great skills. But yeah, of course, as with any new initiative, it does potentially then deplete resources, doesn't it, elsewhere? But yeah, I think in terms of recruiting, I think it is quite an attractive place for people to come to. And obviously the pharmacist as well, we recruited in-house. And then you know, as we said, the rest of the resources within the neighbourhood team. I think in terms of the medic, when we initially did the first bid, we had hoped to have a consultant geriatrician, but that wasn't possible due to recruitment. So that's, that, you know, we have had to refine how the model looks like because of recruitment difficulties in that area.
And finally, Biraj.
Yeah, just a quick one. Firstly, articulate paper. Thank you very much. It was very, very useful. Congratulations to everybody who's been involved in this from the beginning. My point or my question is really about the continued investment of technology and digital, because I can see that making a big impact. You mentioned a few things already. I expect that either now or at some stage we'll learn more about the investment that's necessary to continue to improve our virtual ward services from that perspective.
I think absolutely, Biraj, you know, that'll be part of the evaluation and the recommendations. You know, technology is key to the delivery of this service, this enhanced service. This is the kind of the peak of the pyramid, really, around the complexity of what we deliver in community services, and technology will be absolutely key, and we'll pick up on that and recommend through the evaluation. Absolutely.
Thank you, Rob. Thank you, Kate. It can sometimes be quite easy to overlook the tremendous successes we have in our trust, because as a board, we continually deal with the things that need improving and the difficulties and the problems. Our neighbourhood teams, Kate, Rob, your teams are a tremendous ongoing success in terms of admission prevention, in terms of the frailty wards. This is another aspect of that, and it is so easy to overlook it. You're not overlooked, hence we wanted you to come here today to tell us all about it. We look forward to seeing more success in it, because this is the future. This is the future of healthcare, isn't it? Because the one thing we haven't mentioned in all this is the patient too much. The actual improvement in care for the patient, because they're in their own properties, in their own surroundings, potentially with their own family around them. And I think that's one of the biggest bonuses of the virtual frailty wards system that you've put in, and sometimes that can get overlooked. It would be dead easy to look at numbers and admission avoidance and all those things, but the quality of the care that our patients are receiving in the environment they want through this initiative, I think is something that we need to keep at the forefront of our minds actually on this one. So Kate, Rob, thank you ever so much indeed, and we look forward to hearing more about the rollout and how we're going to improve how we do this and get it into other areas, and we hope the funding comes through for South Worcestershire and everywhere else. Thanks very much indeed.
Thank you very much.
Okay, folks, we're way behind on our timings, but I anticipate the rest of the agenda is what, if there is such a thing as standard, we're just about to approach it. So I'd anticipate picking up some pace. I didn't wish to truncate any of the discussions this morning, because if you had noticed, we've changed the agenda around to put the big meaty items, important strategic items up front to ensure we have those discussions and they aren't rushed. And hence that's why it is as it is. From now on, I think we've got some things that we need to just pick out the salient points and focus on anything that needs our attention. Sue, the next two items have been well trailed through various meetings. I know non-executive directors have been briefed on these at ICB forums. Is there anything we need to say about the joint forward plan, or indeed the operating plan, that is different to what we already know, or can we just note and approve?
No, as you say, Mark, the joint forward plan, you've got your cover sheet, that's standard across all system partners. We have picked up the key elements of this. It is a very long document, but as Martin said earlier, and very comprehensive. Clearly, devil's in the detail, and that's still to be worked through in relation to next year's operational planning and any medium-term financial resource shift, which we would need to see to make this document a reality. So there's no surprises in this document for us. We've considered the contents of this in various forums. So unless people have got questions, I'm happy just to move through to the ops plan.
And it's well worth noting, I think, that Sue and the team have been fully involved in the development. It's not a come out of the ICB as an organisation. It is actually the system plan, and Sue and the team and our partners have been fully involved in it. Hence, we're very comfortable and it's thoroughly socialised. So if we can note that. The operating plan, is there anything to mention about that, Sue?
Sorry, Mark, I should have said in the last one, the system has asked that we formally approve this, which you and Sarah have done by proxy, have been at the ICB. So just to make sure in the minutes that it's clear that, you know, we've been involved with, as you say, the compilation of this, and we've approved it as a board. The system plan, again, we've all been very involved with this. I've got colleagues on the screen that have picked up their respective portfolios. So Elaine and the team for workforce, Rob for money, and we know we've had a number of comprehensive updates around the system financial position, and likewise for the activity and performance. Myself, I've been over the narrative, linking in with colleagues where we've got particular areas of focus for ourselves, so the dementia diagnosis rate, and interestingly the increase in activity against virtual wards, which we've just heard about. So again, I think this has been through various committees and been signed off as part of the composite op plan that's gone forward for the system.
Okay, and again, it's one that we've seen previously and indeed been discussed at ICB forums. If there are no questions, can we approve that as well? It's retrospective a little bit because it's been through the ICB. Okay, thank you very much indeed. Which then takes us through to our performance. And colleagues, you'll notice that we've tried to bring together agendas which have been previously separate items. We put them together to assist the non-exec and the executive to work together and hopefully reduce duplication. And this may, in future meetings, turn into one report, if you like, but we'll see how it goes today. So firstly, quality with Janet, and then Natalie and John as necessary. Janet.
Yeah, thank you. I'll take the report as read and not go through it all, but I wanted to pick out just 3 areas towards the end of the report that link with issues we've talked about already. The first one is the issue of sexual safety for our staff and patients, just to say that we had a report on the work that's happening in respect of that. And at the moment, our assurance levels were quite low, but we've noted the action plan, and we're having a report at the next committee in September, so that we can actually get assurance about progress that's being made. So that's the first thing. The second was the adult ADHD service, which again you reported on earlier, to say that we considered the proposal about ceasing the service in 12 months and looked at that from a quality and safety perspective, and we agreed with that proposal from a quality and safety perspective. And then the third thing was around the place assessments that we had a report about, and I think we're increasingly clear, and again we've talked about it in respect of Hillcrest, the link between the estate and actually delivering high quality care, and felt that actually the place reports could be triangulated usefully with F&P as well as Q&S, so that we actually look at that in the round. So those are the 3 things I wanted to point out, in addition to the actually report that you will all have read. Thank you.
Any questions at all on quality and safety, or can we note that report? Okay, Martin, thank you. Yeah, saw you.
Sorry, I did have one question in relation to the ADHD service, and it's been considered at Q&S, but have we considered it from actually the absence of a service and what impact that will have on those who currently actually get the service, or particularly with our mental health collaboration head-on?
Well, we looked at it from the point of view that actually only a very small number of patients are getting a service at the moment, and that the vast majority are on a waiting list with no anticipation of actually getting a service. But our ICB colleagues obviously commented that they will be looking at this, and looking at it across the system from a perspective of how they can improve that. So I don't know if anybody wanted to add anything to that, from the discussions or from other discussions that they may be having.
I guess I was wondering whether this is an ICB issue or whether it's Mental Health Legislation Committee issue, and I couldn't work out where the dividing line was.
Sarah, did you wish to comment?
I was just going to comment that it was raised in Simon Trickett's Chief Exec report to the ICB yesterday at ICB board. So the ICB are recognising this as a significant issue and prioritising it to agree a way forward. So there is a task force, as Matthew alluded to earlier, there's a task group that's looking at the options around this, but it is being taken seriously in a joint conversation. Yeah, thank you.
Tessa.
So just wanted to clarify, it is an assessment service though, isn't it? So we haven't got patients going into a supported service getting ongoing treatment or support. It is just that they're being assessed. So we won't have a cohort of patients left adrift at the end of it.
I think Matthew got his hand up.
I can say,
yeah, no, just for clarification, Tessa, the service has kind of three functions really. So one is around assessment and diagnostics and prescribing. The other is around regular health reviews of those people that are prescribed, but also in non-medication support to people who may or may not be prescribed. So we've got a CBT therapist in there and also another nurse as well. Just to remind people that the challenge that has preceded us intending to give notice is that the demand for services is around 20 times greater than the commission service level. So that the decision on quality grounds in order to, not continue with this model has been that trying to run a model like this is causing more detriment to the population in terms of building up a huge waiting list than we actually resolve by providing a very, very small service. So the challenge has been put back into the collaborative space. In terms of quality impact, we've undertaken a quality impact assessment, and that's been signed off internally by CPAG, and that was presented as well to Quality and Safety Committee.
Thank you, Matthew. Thank you, Janet. Natalie, from your perspective, quality and safety report?
I don't have anything to add from Janet's very good summary and the report.
Okay, thank you very much indeed. Can we note that and move to workforce?
Thank you, Mark. Just two things that I wanted to note, assuming everyone's read the report. Just that we've got the extraordinary meeting of the Workforce Committee on the 2nd of August, where the action plans and the recovery plans are all coming together as a single agenda item to make sure that we are covering things off effectively. I think the key concerns of the committee are around the pace of improvements, and also concerns around the capacity to deliver all that needs to be delivered around the EDI and culture pieces. And I think one of the challenges, particularly for the recovery plans, is that it's very different for the workforce ones compared to the performance ones, where there's monthly performance data that can be looked at. A lot of the indicators and metrics for the workforce ones around the equality and diversity and the improvements rely on the pulse survey and the staff survey. And so, for example, we're going to have a long period where we get nothing because we don't do a pulse survey when the national staff survey goes out in the autumn, which means actually we're likely to have a void until after the July pulse survey has been reported on, through to when the staff survey is reported on, which is usually about February time. So we need to make sure that the other indicators that we've got in the workforce realm are effective proxy indicators on the staff voice and staff well-being in particular. So I think there are some specific challenges around this that we need to pick up at the Workforce Committee when it meets in August.
Anything to add there at all, Elaine?
Thanks, Chair. Only on the point of the EDI agenda, because my sense is the Trust, having signed the NHS Confed inclusion pledge, does follow with some specific actions for us as a board, but across the wider organisation as well. So that's a piece of work that we will have to pick up in fairly short order. And then additionally on the wellbeing piece, we have had notice that there's small amounts of money we've been given as a region, which may help us to shore up our health and wellbeing offer to staff, but probably in the space of getting some curated content. Those are my only two additions, but pretty much what Tessa said.
Thank you, Elaine. Jamie.
I got a couple of questions on not the workforce committee report, but the subsequent detail workforce report. Is now the time to ask them?
Yes, certainly.
Right.
Please.
I'm concerned to see the continuing low level of leaver response rates to leaver survey, and I know we've discussed this in the past, but it doesn't seem to be shifting, Elaine. I wonder if there's more we could do. I know in other employers, in other organisations, it's not uncommon for leavers interviews, leavers risk surveys to be pretty much a mandatory requirement of employees. I'd like to know what more we could do to boost that. And also in relation to appraisal rates, there's a very sharp dip shown in May, and I wondered what the cause for that was. I know that when we've looked at the low appraisal rates, it's been explained that the difficulty of conducting appraisals in clinical settings, particularly in the period of difficult stress and pressures, but there seems to be a bit of an inconsistency in saying that, where elsewhere in response to staff survey results, what we're trying to do here is improve and strengthen the relationship between line managers and employees, and surely the regular appraisal is a fundamental part of that.
Yeah. So if I can respond to your first question around leavers data, Jamie, we have had a conversation very recently around, and I call it light mandating, because there is the issue of who's going to do it and then how it's done. But we are, I think, probably moving towards the light mandating of. The issue we have is around possibly some of the relationships that line managers and staff don't have, rather than have. Where they're great, it happens. Where it's less so, there is a reluctance for managers to undertake it. I've certainly done 2 exit interviews, leavers interviews very recently, specifically on the basis of not wanting it to be done by their immediate line manager. Now that then becomes a capacity issue if everyone wants to do that. But what we want to do is encourage a culture where you have the conversation, however difficult it might be. So we're looking at how we can make that pro forma and that process a little slicker, but actually also more informative. On the basis of on the issue of appraisal, we know that managers are telling us that they're incredibly busy. And I guess my response continues to be, this is a really important part of building those line manager and employee relationships. It's not about the frequency, it's about the quality of. They have to take place, whether you're doing that on a bi-monthly basis or a monthly basis, but it's a way to get information about those early warning signals, which may be about someone's potential to leave, or that there are other kind of issues that need to be picked up by the line manager. So we're still looking at how we can ensure that that's done. And some of that may also be about the amount of paperwork we're expecting managers to complete. We're again reviewing, probably for the 3rd time, the paperwork being as minimal as possible, but as informative as possible. And then the other piece that I'm trying to encourage our managers to work with is the notion of probably appraising a smaller group of people where there are broadly similar objectives that they can work through. That's not to take away the individual nature of an appraisal, because it's important managers do speak to people on a one-to-one basis, but we're trying to explore any number of ways in which we can do this.
Thanks, Elaine. And there's a suggestion from Tessa in the comments. Last word to Biraj.
Appreciate we're running out of time, Chair, so I'll be quick. EDI plan has just been introduced nationally last month. CQC's feedback includes EDI and cultural change. We've had a senior day out on inclusion where a lot of people invest a lot of time talking about it. So clearly the whole subject is right up there on our agenda. I just wanted to get a feel for when we should expect, when it's reasonable to expect that we'll see some plan of action around what we're going to do to implement those pillars, those 6 pillars that we
and I would say that's probably part of our discussion later on today. We've certainly been discussing it as execs about what we can do in the immediacy of responding to CQC. So definitely we can pick that up, Biraj, but we have some things in,
Thank you.
It will be within the time frame that we have over the next 3 months.
Okay, thank you. If we move from workforce to F&P, ably supported by Robert. Steve first, I suspect.
Thank you. Just a couple of things to note. The EPR outline business case that we'll discuss in later because of commercial reasons. Obviously, that's been approved to go forward to Trust Board to approve it, and we also approved a project budget increase for the Eliminating Dormitories project. So just to note those 2 things, happy to take questions on the rest of it.
Any questions at all on F&P? Robert, performance.
Thanks, Chair. Just a couple of points on performance then, really. And I know Matthew picks generally a few of these up in his operational report. So Sarah's already referred to the segmentation, so that's important. That's there for all board members to be aware of at the start of the report. The other key one I wanted to draw out, Chair, was just around the oversight framework. You'll have seen that whilst we've had publication from the NHS England team around the metrics that they consulted on, we're still waiting for the thresholds and actually which ones of those they're going to assign levels to. Normally that's July. We haven't had it yet, actually, which is a little unusual. So that's leaving us a little bit in the grey at the moment, exactly where we are. So we're using last year's metrics where appropriate, and obviously we've been keeping committee updates in terms of performance against likely new ones. The other items I think we've covered, including the claim notes part earlier. I'll pause there.
Finance, Rob.
Yeah, finance. There are a couple of items I do need to draw out for the board's attention. First one is that at month 2 we are slightly off plan, so that is important. We are still forecasting that we will achieve our plan by the end of the year, but this is just an indication that it is, it is tight. It is a difficult plan to deliver this year. Key metrics you'll see in terms of efficiency, we're on track. Agency is reducing in line with where we'd hope to be at this time of year, albeit noting it does require further improvement later in the year. Capital programme at this stage is on plan, and other than noting the revenue, that's the issue. The other bit I'd just draw out is that as a system we are off track. So the system plan at month 2 is under pressure, and we've been asked to include some additional controls on expenditure by the regional team and the national team, and that's a result of having a system deficit plan. So that's all providers in the system, and we're just working through some of that. Comms has gone out to staff this morning around the overall position, and then we've got one that we're sending to budget holders and recruiting managers in particular around a reminder of some of the controls we have at the moment, but also some new processes we need to put in place around additional checks around recruitment and non-pay expenditure. That's it, Chair.
Rob, could you offer comment on anything that's emerging from month 3, i.e., I appreciate the figures are being collated, but is there anything you know about month 3 in relation to the revenue slight overspend we had? Has that been halted? Is it changing, increasing? I appreciate the figures haven't been fully collated, but is there anything you can offer us now?
Yeah, so month 3 fast track is that we have we've steadied the run rate. So actually the overall shortfall has reduced by about 10,000. So we're still off plan, but we've arrested the in-month deterioration. So clearly early days, but that's a little bit more positive.
Yeah, that's good news. Just that it's been arrested and isn't running away, so to speak. That was what I was after, to see if that was the case. Thank you very much indeed. Can we note the performance of finance reports, please? Which then takes us to Martin and Audit Committee.
Yeah, the Audit Committee in June was focused on the closure of last year's accounts, so very happy to formally report that we had an unqualified audit report and significant assurance from internal audit. I don't underestimate having a unqualified audit report, and particularly, should I say, we benefited from having new auditors, and I mean that genuinely, but also it did mean that Robert and his team had quite a lot more questions and scrutiny and different procedures to get used to, which thank you for the team for standing up to the plate on that. But I think they did bring a different perspective, and it been generally very positive in terms of the quality of the audit and the information they reported back to us.
Thank you, Martin. I went along to the Audit Committee, and I would offer also Robert, Charles, Denise, the teams. I know that you were delivering it in some difficult circumstances with new auditors. The new auditors reported good relationships, as we did. It's not always the case everywhere. So congratulations to you and your teams, Robert, for delivering a good audit, and thank you, Martin, for overseeing through Audit Committee. No questions there. Mental Health Collab, Jamie.
Thanks, Mark. The assurance levels we gave to performance, finance and quality were the same as before. The reason for the no assurance on the workforce element was because, despite some excellent work put in by Elaine and colleagues on the trust's aspect of this, we're still waiting for contribution from partners. I think the other thing I wanted to draw attention to in the discussion was on the transfer update, and you'll see there that as a result of discussions on capacity within the system, but also level of risk, and also any implications of CQC decisions, what we're now looking at is a transfer date being put back to the 1st of April rather than the 1st of October. And I think we'll be discussing that probably later on and over subsequent weeks.
Thank you, Jane. Any questions on that? And yes, so we have a small session on that later. The main thing is the work carries on and the products are being done, and the governance isn't quite as important as the work that's carrying on between all partners, which I think, Jamie, you can confirm is still forging ahead as anticipated.
Absolutely, that is indeed the case.
Yeah, good. Thank you very much indeed. If we could note that report then and move on. Jamie, again, anything to say on charitable funds at all?
We did what the report says, but the only thing I did want to mention, being a bit naughty, I know, but it's nothing at all to do with the report, but just to mention that the Dementia Garden at Newhaven, which is a charitable funds project, was launched by Mark earlier this month, and it's a terrific example of a really good project involving staff from the bottom up and patients and their carers. It's a terrific example of how charitable funds can make a real difference.
I can only echo that, having been out with Jamie and Rob on that day. Anybody that is in that area and wants to look at how therapeutic the funds have been used to make it better for staff and our patient cohort, it's a fantastic initiative. And is seen as a bit of a market leader across the country, I understand, and there's a lot of interest from elsewhere in it. So congratulations to all those who are involved in that. Thank you very much. Matthew, operational update.
Okay, obviously going near to last, I think inevitably most things have been covered elsewhere. Just a couple of points that we haven't covered. One around inappropriate out-of-area placements. Our oversight framework in the long-term plan target is 0. We've achieved this recently through performance improvement plans that the associate medical directors and ADs have agreed. And also a reminder that achieving 0 out-of-area placements, or very low numbers, certainly is part of our system financial plan as well. Over the past month, some concerns have been expressed by senior clinicians about some of the consequences of driving a no inappropriate out of areas target, consequences around the use of the 136 suite, so people waiting for too long for admission to a local bed, and the number of working age adults on older adults' mental health wards. Some of those appropriately, but some of those, who could have been better placed elsewhere. There's a view from some senior clinicians as well that the focus on length of stay and flow is too prominent, and they are urging the trust to investigate further whether we have adequate bed numbers. And we've met with them to agree immediate actions, which have been agreed to everybody's satisfaction. We're meeting again in the next couple of weeks as well to agree further actions that are acceptable to clinical and operational leads and will help us manage the situation locally. That's probably as much as I need to say on that. I'd just draw attention as well to, I know it's been discussed from time to time, but the number of vulnerable services provided by the Trust. Some of our smaller services are a challenge to deliver with even minor staff movements, and some of that's played through in the risk register, and I've listed a few examples there, but really I could probably give you 10 to 15 services that are provided at a very small scale that would mean one or two staff left or moved. It would be very challenging. It's been discussed previously as a system and through contracting meetings without good resolution. I think everybody accepts there's no easy answers here, but I'm proposing this is something that should be revisited at an ICS level, because I think there are probably opportunities here to re-examine what optimal delivery models might look like and create some more sustainable and resilient pathways. And I wouldn't want us to lose sight of some of these services just because they're small, because it's the fact that they are small that causes problems for them to appear on our risk register when we have even minor staff movements. So that's probably everything I need to update for my ops report.
Thank you, Matthew. And there's a good reminder in there that whenever we talk about bed pressures, very often it tends to be through the acute setting and into our community hospitals. We continue to sustain bed pressures within our mental health beds, and sometimes that can be overlooked. And I know Matthew has to deal with it on a daily basis. So that was a piece of work that's well founded, Matthew. Thank you very much. Nothing. If there's, yes, Sarah.
It was just a comment on the vulnerable service, Mark, because obviously often it is looked through a system lens, but I just wonder if we ought to think about either via Q&S, don't know what Janet thinks, or via board development, have another session on what our most fragile services are, because I think obviously time moves on and we've got a number of new non-execs. So I just wonder if it's worth looking through that lens, looking at the whole of our service portfolio, which ones are fragile and why, just so that we're all on the same page around that. So I don't know whether you think that's Q&S or a board development, but I think it'd be helpful.
I think it'd be extremely helpful, Sarah. I'm not sure where. It feels like the entire board for a development session actually at some stage, but I know that those sessions are starting to become packed. So let's have a discussion outside, Sarah, as to where we can take it, whether it's a subcommittee or whether it's a wider awareness session, because I think you're absolutely right to bring us all onto the same page. Thank you. If there's nothing else from Matthew, the next item on the agenda, the quality account, it says for approval, but they've already been approved through delegations at Q&S and actually indeed submitted. So I would suggest we just note them unless there's anybody got any specific questions about items in the quality account. Jamie.
It was actually on that question of approval, because it wasn't clear to me which body has authority to approve the quality account. If it's been approved by a committee, why has it come to board? We've got the next item, infection prevention and control, ask the board to approve it, although Q&S has already apparently approved it. It may be me, but wouldn't it be simpler if things are going to come to board via a committee, that the role of the committee is to recommend its approval by the board, and if it is actually signed off by the committee, it doesn't need to come to the board.
Jill will give you a very eloquent answer.
So the quality account is usually approved by board if timing permits, but because of the timing of it, board delegated authority to Quality and Safety Committee, but it's a document that is required to be received by the board, which is why it's separately on the agenda. The annual report on infection prevention and control is one of those small anomalies that obviously it goes through the Quality and Safety Committee and they do the deep dive on it, but the board are required to receive that, and that's why it's separately identified on the agenda rather than in the item 26, which is reports that are important but have been considered elsewhere, and it's about a requirement for it to be received by the board.
But not approved by the board. Are you saying that the IPC is approved by someone else, but we have to see it, or we have to approve it, in which case someone else hasn't approved it?
So I understand the IPC has to be signed off by Natalie as the director responsible for infection prevention and control, but it's such a critical part of the trust operating systems, and the national requirement is that it's received by the board, although signed off by Natalie as the relevant director.
Hence, it's here for assurance and not for approval. If you on the agenda, it indicates it's for assurance because it's already been approved by Natalie as per her statutory function. But it has to come here, like Jill said. There are some anomalies, which is why they're down the bottom of the agenda, to be honest. Jamie, for that reason, there are anomalies we have Lords and Masters we have to comply with. We try our best to do it without causing too much aggravation. So can the quality accounts are for noting, and the IPC report is for assurance, as just explained. Does anybody have any questions on the IPC report at all? It's been through QNS. No, okay, thank you very much. We'll take that as noted, which then takes us to there's a list of reports that have been considered elsewhere for our information there: mortality, patient safety, and PALS. You'll notice on the agenda that there's 3 items which have been documents which have been signed. Is there anybody got any questions on the Warndon, Worcester City or Redditch deals, so to speak, there? No? In that case, they can be noted. There were no AACs in that time frame, which is always a disappointment because that means we've not appointed any consultants in that time. Which takes us then to item number 29, which is there anything we've heard today that needs to be included on the board assurance framework? The one I would throw into the mix, and I don't know how and where, is of course our CQC. But of course, we haven't had the full report yet. So I think it's a look forward to when we do receive that. We need to work out how it will fit into our board assurance framework. Would that be a way of dealing with that, Jill? I look at you as the expert on this. Yeah, so I think certainly we've first heard about it today through Sarah's report, and we need to be ready to include it in some way in our board assurance framework, not necessarily the whole action plan, but elements of it and where they sit to make sure we don't allow them to affect our objectives as an organisation and we keep oversight of them. Okay, if we're comfortable with that. Has anybody got anything else that they think we've heard today or has come to mind that should sit on the board assurance framework or amend the board assurance framework in any other way? No? Okay, thank you very much. I've not been notified of any other business at all. Nothing urgent, nobody signalling. Thank you very much. Our next board meeting will be on meeting in public is on the 21st of September. We do meet for our private items now. I would suggest, colleagues, that we come together for that meeting at 1:45, take a just over 5-minute break. We then have an hour and then we'll have a break and then we come together, as you know. So it's a bit of a late lunch. Thank you ever so much for your contributions, and thank you for sticking with it. It's some big meaty items in there today, and they'll undoubtedly need more discussion as we go forward. The one apology, Debs, I didn't welcome you to the meeting at the beginning. Debs is our new chair of staff side and here for observing. If there are any questions at all, Debs, at any stage, any of the executives or indeed myself or non-executives will always engage with you and answer any questions that you may have outside of the meeting. But thank you for your coming along and your interest today.
Good to see everybody. Thank you.
I'll see everybody at 1:45 on a separate